Professor Tanaka, please.
Yeah, thank you very much for Professor Lin and moderator Professor Arao. And it is my great pleasure to be invited to this wonderful seminar. So you can have my pre-recorded video. So please view that video.
Hi everyone, this is Atsushi Tanaka from Tokyo, Japan. It is my great honor to be invited to this APASL School e-learning seminar series for students and fellows. And I sincerely appreciate APASL President Professor Lin and moderator Professor Lau. The title of my today's talk is my algorithmic approach to management of acute presentation of autoimmune hepatitis. So this is my COI. Okay, let me start with this slide. It's the summary of autoimmune hepatitis. AIH is an autoimmune liver disease characterized by chronic destruction of hepatocytes. Also, all the autoimmune reactions against hepatocytes is a main feature of pathology. The precise etiology still remains unknown. And middle-aged women are at highest risk for developing AIH, but observation of AIH in childhood is not uncommon. And insidious development and slow progression are common features of AIH, and eventually leading to cirrhosis and even hepatocellular failure when lacking appropriate treatment with immunosuppressive drugs. And this is my topic today. Today's topic, and acute presentation of AIH does occur. All the precise epidemiology data of acute presentation of AIH is not available. A summary of clinical studies suggests that 20 or even 50% of AIH develop as acute presentation type. So it is not a rare event. And I proudly announced that the first ever the Asian Pacific Association for the Study of the Liver APASL clinical practice guidance, the diagnosis and management of patients with AIH was officially published last year in Hepatology International. And this clinical practice guidance comprehensively describe the epidemiology, etiology, and diagnosis and management of autoimmune hepatitis, focusing on the Asia Pacific region. So please be familiar with this guidance, and please use this guidance in your daily clinical practice. So in terms of diagnosis of AIH, so it is should be keep in mind that AIH is a clinical diagnosis. I mean, there is not a single biomarker which confirms the diagnosis. So it is quite different from PBC, where anti-mitochondrial antibodies, which is highly specific for PBC, is available. So the diagnosis of AIH relies on the following four items. One, the elevation of transaminases, and two, the presence of other antibodies such as anti-nuclear antibody or anti-small mouse antibody. And three, an elevated IgG in sera. The four, typical or compatible histologies. So you can see in this figure, typical histology of AIH, massive infiltration of mononuclear cells and interface hepatitis. And the 5/5, we need to exclude other etiologies such as HBV, HCV, drug-induced liver injury, and NAFO, alcoholic liver disease. And the scoring systems for diagnosis are available. Yes, the International Autoimmune Hepatitis Group proposed two diagnostics scoring system. The first one was called Revised Diagnostic Scoring System, published in 1999, which is comprised comprising of more than 15 clinical variables, which are relatively specific for autoimmune hepatitis. And this scoring system was designed to extract true AIH for mainly research purpose, not for clinical purpose. So it seems that to be too complicated for daily use in clinical practice because of many diagnostic indices. On the other hand, simplified scoring system in 2008 comprised of only 4 items. So autoantibody is positive, IgG elevation, and liver histology, and absence of viral hepatitis. The typical histology include these features. So that's why simplified scoring system is very user-friendly and easy to use in daily clinical practice. So in this slide, I'm going to show you my original diagnostic algorithms for diagnosis of autoimmune hepatitis. So first, we start with elevation of transaminase ST and ALT, either acute or chronic. And we should conduct virological screening for HBV, of course, HAV, HEV, imaging studies, and history taking for alcohol consumptions and presence of suspicious drug exposures, and test ANA and IgG. And when we can exclude these other etiologies, if the ANA, serum ANA was positive and the IgG was elevated, the final diagnosis is very likely to be classical AIH. But ANA could be negative, and serum IgG level could be normal or elevated. And please keep in mind that in any case, in classical AIH or not, we should conduct liver biopsy to confirm the diagnosis of AIH, either practice or transjugular. And when we are able to observe the typical findings on liver histology, such as interface hepatitis or plasma cell infiltrations, the diagnosis of AIH was confirmed, and should promptly start treatment with corticosteroids. On the other hand, when we fail to observe typical finding, when we observe only atypical findings, still we should suspect diagnosis of AIH and consider a treatment with corticosteroids. And in addition, it is very important to keep in mind that when the first diagnosis is DILI, and when the optimal response was not observed even after withdrawing the suspected drug, we should reconsider the diagnosis might be autoimmune hepatitis, and should conduct liver biopsy. Because the differential diagnosis between DILI and autoimmune hepatitis could be very challenging. Some cases with DILI were seropositive for anti-nuclear antibody, and as I told you, some cases with AIH are ANA negative. And the same are true for NAFO. And the differential diagnosis between NAFO and AIH could be also challenging. Between some cases, but NAFO are seropositive for anti-nuclear antibodies. So in any cases with elevation of transaminase, in any case of hepatitis, and especially those without distinct etiological markers such as HBV or CV positivity, the possibility of AIH as diagnosis, the final diagnosis, should remain, and treat liver biopsy and the treatment with corticosteroids would be alternative choice. So yes, treatment for autoimmune hepatitis is simple. ASD guidance recommend that monotherapy with corticosteroids or a combination of prednisolone and azathioprine. And also, these guidelines recommend that treatment should be started with 0.5 to 1 milligram per kilogram per day of prednisolone, followed by addition of azathioprine. So in any case, treatment with immunosuppressive drugs are a mainstay for treatment of autoimmune hepatitis. Okay, so let's move on to the main topic of today's my talk, acute presentation of AIH. I'm going to talk with about definition, diagnosis, and treatment. So let's start with the definition. Acute severe AIH, acute presentation with AIH is divided into acute severe AIH with acute liver failure, and acute severe AIH with acute on chronic liver failure. It seems to be very complicated, but it's not so complicated. Now, although the precise definitions are available for the moment, most of the clinical studies agree the definition shown in this table. Acute AIH is a disease with jaundice, and acute severe AIH is autoimmune hepatitis with jaundice and coagulopathy, which is defined as more than 1.5 INR. Okay, and acute severe AIH with acute liver failure is acute severe AIH with hepatic encephalopathy. And another form of this type, acute severe AIH with acute on chronic liver failure, is acute severe AIH based on the chronic liver disease, mainly cirrhosis. And it doesn't matter whether hepatic encephalopathy is present or not. This definition is based on the APASL guidelines for ACLF. So, how to diagnose these pathological conditions? So, please look at this case presentation 1. The first case is a 52 years old female, and jaundice developed 7 days ago. And at presentation, consciousness was alert, and the patient denied any liver disease in the past, any alcohol drinking, and any current medications. The biochemical parameters at presentation include prolonged INR 1.8 and elevated transaminases, and bilirubin 15.1, and hepatitis viral marker were negative, and ANA negative, and IgG was elevated. So what is the diagnosis of this case? What do you think? So let's get back to the algorithms. We can confirm the elevation of transaminases, and we can exclude viral hepatitis and alcohol or liver disease. And I didn't show you any evidence, but we can exclude NAFO, and we can also exclude DLA because the patient denied any medications. And in this case, ANA was negative and the IgG was elevated. So anyway, we should conduct liver biopsy. And because of the prolonged INR, we conduct liver biopsy via transjugular route, demonstrating central lobular necrosis and inflammation, and the cobblestone appearance of hepatocytes and plasma cell infiltration in liver parenchyma. And importantly, the fibrous staging was very low, 0 to 1. So according to this definition table, this patient was diagnosed as acute severe autoimmune hepatitis because this patient has jaundice and coagulopathy, but not hepatic encephalopathy and not cirrhosis on the basic on the background liver histology. And if this patient had hepatic encephalopathy at presentation, the diagnosis would be acute severe AIH with acute liver failure. Okay, and let's think about the utility of a scoring system proposed by International Autoimmune Hepatitis Group. So as I told you the two scoring systems, especially simplified scoring system, is very easy to use and useful for daily clinical practice. But this scoring system is not so useful, not recommended to be used for diagnosis of acute severe hepatitis. For instance, one study demonstrated that in acute onset hepatitis, probable in the defined AIH was 51% and 40% using revised AIH criteria, as you see, and only 29% and 11% using simplified AIH criteria, just like this. So the diagnostic value of these AIH criteria is very, very low compared to classical AIH. Another study also demonstrated that in acute severe AIH with ALF, the probable and definite AIH was only 24% using revised criteria and 40% using simplified AIH criteria. So one author of these papers suggests that IHG scoring system should not be applied to any case of the acute severe AIH. I don't think systems should not be applied, but it is true that this scoring system is not so useful, has lower diagnostic value for acute severe AIH. So these facts clearly highlight the unmet need for new diagnostic criteria for acute severe autoimmune hepatitis. So let's look at another case, the case presented to 29-year-old female, and jaundice developed 45 years ago and remained icteric until presentation. And consciousness was allowed, but there was a clinical ascites at presentation. And the patient also denied any liver disease in the past and no any alcohol intake and current medications. And the biochemical parameters also demonstrate that NR 1.9 and a mild elevation in transaminases, bilirubin 8.2, and viral markers were negative. In negative, IgG was elevated. So what is the diagnosis of this case? Again, liver biopsy via transjugular route indicate the answer, the diagnosis. The central lobular necrosis inflammation, cobblestone appearance, hepatitis, plasma cell infiltration, liver parenchyma are similar to those in first cases. Actually, these are typical findings in the acute presentation of the hepatitis, but the difference from the patient one, case one, is the fibrotic stage. So in this case too, the fibrotic stage was 4, almost cirrhotic. So again, according to this diagnostic table, now we can diagnose this patient as acute severe autoimmune hepatitis with ACLF, acute chronic liver failure. So what is the difference between ALF and acute chronic liver failure? According to APASL guidance, guidelines, ACLF is defined as an acute hepatic insult with jaundice, coagulopathy, clinical ascites, and/or hepatic encephalopathy in a patient with diagnosed or even undiagnosed chronic liver disease or cirrhosis. So if the patient denied any chronic liver disease in the past, the possibility of ACLF still remains. And although it is difficult to distinguish two conditions, histological features are distinct. I mean, in acute liver failure with AIH, lymphoid aggregates and perivenulitis are main features in liver pathology, while advanced fibrosis and ductal reactions and the large areas parenchymal collapse with lymphoplasmacytic inflammation, especially advanced fibrosis F3 or F4, is characteristic in patients with AIH, ACLF patient. Okay, so then how to treat these patients? For patients with acute AIH, acute severe AIH, and acute severe AIH with acute liver failure, it is recommended that treatment with prednisolone 0.5 to 1 milligram per kilogram per day, either oral or IV, would be the choice. And it is important to assess response to corticosteroid treatment at day 3 of treatment or day 7. And if the treatment response is favorable and the improvement of symptoms or biochemical parameters are observed, we should continue the treatment with prednisolone or consider the addition of azathioprine. But if the response at day 3 or day 7 was not optimal and no improvement was observed, we should consider the second-line treatment, such as tacrolimus or mycophenolate mofetil, or should assess the patients for liver transplantation in patients with acute autoimmune hepatitis. But in more severe cases, such as acute severe AIH or acute severe AIH with acute liver failure, we should stop corticosteroid treatment if the response was not favorable, and need to list the patient for liver transplantation. Especially this is very important for patients with acute AIH with ALF. Otherwise, the timing for liver transplantation would be very delayed, leading to mortality. Then, I'd like to address 3 points to be discussed. The first one is what are predictors treatment and presentation. And the second, which route would be favorable, corticosteroid, oral or IV? Or what about those? And third, how and when to assess the treatment response. So the previous clinical studies, a number of clinical studies demonstrate that response to corticosteroids can be predicted at the baseline and may be favorable in patients with younger age and no ascites, low-grade hepatic encephalopathy, and lower bilirubin and INR, the absence of massive hepatic necrosis, liver histology, and lower MELD score. So, I mean, the response to corticosteroid may be favorable in younger patients and milder cases. And in terms of administration route and dose, there are no strong data to suggest that an IV route is superior to an oral route. This is mainly because of a variety of the previous clinical studies. For instance, recent multi-center study for autoimmune hepatitis actually not acute severe AIH, not the classical AIH, from European countries suggest that low-dose corticosteroids provide similar response rate compared to high-dose corticosteroids. But by contrast, another recent study from Greece demonstrated that prompt high-dose IV corticosteroid for acute severe hepatitis seems to be beneficial and seems to be associated with better outcomes in patients. So, therefore, the optimal corticosteroid dose and route of administration has yet to be determined and needs further evaluation. And the final matter to be discussed is how and when to assess response to corticosteroid treatment. The recent French study, multi-center study, suggests the surface score using INR at the presentation and INR and the bilirubin at day 3 are very useful to assess response to corticosteroid treatment. So the surface score should be utilized for determining the needs for liver transplantation. And another previous studies suggest that these indices are useful to assessment of response, including improvement of MELD score from day 3 to 14, and MELD sodium or bilirubin became model for end-stage liver disease scores at day 7 compared to the presentation, an increase of INR or bilirubin at 2 weeks. So anyway, so we need to assess the response to corticosteroid treatment at day 7 or at day 3. I mean, at the earliest point. So especially for the sixth cohort, such as those with hepatic encephalopathy, assessment at day 3, a very early point, requires further evaluation and will be very important to determine the need for liver transplantation. What about treatment for patients with acute severe AIH with ACLF? In fact, there are a few studies assessing ACLF in patients with autoimmune hepatitis. One of them from India in 2019, comprising of 82 patients with AIH with ACLF. 34% of patients received corticosteroid treatment, and the 90-day survival was 75%. And they demonstrated that corticosteroid treatment significantly improved 90-day survival. So they conclude that corticosteroid treatment is recommended in patients with acute ACLF in patients with AIH. But by contrast, a more recent study from India, comprising of 48 patients with AIH and ACLF, 60% of patients received corticosteroids, but 90-day survival was down to 55%, compared to 75% in the previous study. And furthermore, 79% patients required steroid discontinuation because of various clinical reasons. So, in summary, it seems that a short trial of corticosteroids should be initiated when inflammatory activity is present on liver biopsy and no active sepsis is detected. But please note that a short trial, so the treatment response should be monitored after a short administration of corticosteroids. And the final study by Sharma suggested that the patients with no extrahepatic organ failure with good baseline predictor scores such as MELD or CTP may benefit from corticosteroids. Okay, in conclusion, acute severe presentation of AIH is not a rare event, and the diagnosis is challenging because of lacking serological biomarkers and the unmet need for new diagnostics criteria for ACLH. And the cross-control to be administered, and the predictors of presentation include these items. And importantly, assessment of response should be closely monitored, especially within 3 days, especially in the sickest cases. And thank you for your attention, and I'm very happy to accept any comment or question. Thank you very much.
Thank you, Professor Tanaka, for your excellent speech. And anyone who has questions, please stay at the final session. Now I'll hand the chairmanship to the Professor Lau. Professor Lau, please.
Thank you, Professor Lin. And I think that Professor Tanaka has given an excellent talk to the level of state-of-the-art lectures in autoimmune hepatitis. I'm sure the audience in Asia Pacific regions would benefit from the lecture. Our next sessions will be have speakers from Professor John Waring. He didn't need any introductions. He's certainly one of the key opinion leaders in the field of hepatology. Knowing John for almost close to 3 decades, he didn't show any sign of tiredness in the field of hepatology. And he is now the Professor of Medicine and Surgeries, the Chief of Hepatology and Director of Baylor Liver Health at the Baylor College of Medicine in Houston, Texas. And he was the president of American Association of Study of Livers and also the chairman of the National Board and the directors of American Liver Foundations. The topics assigned to the Professor Waring today is the algorithms to approach to the management of overlap syndromes of cholestatic variants of autoimmune hepatitis. So John, please.
Well, thank you very much, Professor Lau and Professor Lin, and to the organizers. I will open my presentation here and go to full screen. If I can find full screen here. With me here. So again, I thank the organizers for the opportunity to provide my algorithmic approach to cholestatic variant or overlap syndromes. These are my disclosures. Now, historical perspective of overlap syndromes begins with Charcot, who said that disease is very old and nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. And many would be interested to note that Doniak and Walker first discussed the involvement of active chronic hepatitis, primary biliary, and juvenile cirrhosis, saying overlap of these distinctions are not uncommon in the early as the 1960s. Now, I want to give my endorsement to the concept of cholestatic variants as the terminology versus overlap syndromes. And that is because of the clinical utility of that concept of cholestatic variants. It forces the clinician for consideration of other causes of cholestasis, such as new onset biliary obstruction or cholestatic hepatitis due to viral agents or drug inductions. In particular, herbal and dietary supplements that the patient might be taking. So we don't want to default immediately to think that we only are dealing with overlap syndromes in patients with autoimmune diseases. Now, this looks at those cholestatic variants of autoimmune hepatitis, and they come in 3 classifications. To the left, we see we have the patient with verified PBC. And we're interested in whether they have a PBC AIH overlap syndrome. And the issue is, are they presenting concomitantly at the time of diagnosis or later after verification of PBC? Did they develop evidence of autoimmune hepatitis? That clinical context is important, as we'll discuss in a patient in a moment. In the middle, we see the verified PSC patient. This is a large duct patient, meaning macroscopic evidence of strictures on MRCP or ERCP. And again, we have a concomitant presentation with possible autoimmune hepatitis. And you're all aware that that is most common in children, where it has been referred to as autoimmune sclerosing cholangitis. And then we also have the sequential onset in adults with verified PSC. And to the right, we see the verified AIH patient. And then we have the PBC overlap in the AMA positive. And I call attention to the fact that we have no criteria for the diagnosis of overlap syndrome in the AMA negative, although one could make the case that PBC-specific anti-nuclear antibodies could be the surrogates for a positive AMA. And to the right, one sees PSC, and that requires large duct PSC. So one teaching point of emphasis is there is no defined overlap syndrome with small duct PSC and autoimmune hepatitis. Now, PBC is characterized by lymphocytic cholangitis, shown here in small caliber bile ducts and medium caliber bile ducts with T-cell mediated infiltration of the epithelium with destruction. You're all aware of that. This looks at PBC in the ductular reaction, which to the left with immunostaining is characterized by marginal proliferation of cholangioles at the inflamed portal tract border with the parenchyma of hepatocytes. And this leads to the projection of septa of fibrosis, which willy-nilly bisect the liver as shown to the right, creating a so-called jigsaw puzzle appearance in the cirrhotic liver. This is characteristic of biliary cirrhosis and not the characteristic of the post-necrotic cirrhosis that one sees in viral hepatitis, autoimmune hepatitis, and for NASH for that matter. Now, I call those two things to your attention because classic autoimmune hepatitis is commonly associated with biliary pathology. This large study of Verdunk from the Netherlands showed that bile duct injury was present in 83% of the biopsies, and it was not evidence of small duct PSC. These were bona fide cases of autoimmune hepatitis with response to immunosuppressive therapy. The ductular reaction occurred in 71%, and when you used immunostaining, you could find it in 94% of autoimmune hepatitis patients. It had correlation with the intensity of interface hepatitis and central lobular necrosis, and it was persistent in the majority of biopsies up to 2 years later. So we have to regard biliary pathology as being a typical finding in autoimmune hepatitis, and it should not lead us astray in thinking the patient with such pathology has an overlap syndrome. Now let's turn to our first case. That's a 70-year-old woman who presented for evaluation of abnormal liver tests. She had been fatigued for several months. Her primary care physician detected abnormalities, and she had a past medical history of hypothyroidism and lichen planus, two bona fide extrahepatic autoimmune diseases. She was retired. She had no significant alcohol. She had no particular symptoms other than fatigue. She was well appearing. She had no stigmata of chronic liver disease, as illustrated in her physical exam. Now, we know that AIH has strong associations with extrahepatic autoimmune diseases, which are listed to the left. To the right, we see this population study from Denmark showing their frequency beginning in childhood in both males and females with AIH. So it is not uncommon, therefore, for a patient with an autoimmune liver disease, such as AIH or PBC or even PSC, to have extrahepatic autoimmune disease associations, which tips us in the direction of consideration in this woman presenting for evaluation that she might have an autoimmune disease. Her medications included treatment for hypothyroidism with levofloxacin, omeprazole. She had no herbal or dietary supplements. Now, Her laboratory tests showed a substantial elevation in alkaline phosphatase to greater than 2 times the upper limit of normal. Her total and direct bilirubin were normal. And she had a great elevation of ALT and AST, the ALT being 5 times the upper limit of normal. Her albumin was normal, her PTINR was normal, and she had 3 autoantibodies, ANA at a high titer with a centromere staining pattern, AMA at a high titer, and SMA, an ELISA for F-actin at a substantial positive result. She also had the mixed presence of an elevation of IgG and IgM immunoglobulins. So let's take a look at this patient. We now have her history, her physical examination, her medications. We've reviewed her laboratory, and our next steps are to consider imaging and liver biopsy. Now, of course, in the laboratory, I've not given you all the negative tests for viral hepatitis and other issues that are pertinent to the differential diagnosis. But I want to pursue both imaging and liver biopsy as our next approach to this patient. The abdominal CT was our choice in this patient. I usually prefer an MRI with and without gadolinium contrast, but she was claustrophobic. It revealed borderline hepatomegaly, the absence of biliary dilation, cirrhotic nodularity, and she had no masses or collateral vessels indicative of portal hypertension. She had a normal gallbladder without cholelithiasis. Her percutaneous liver biopsy, shown here to the right, showed portal lymphoplasmacytic infiltrates. She had moderate lymphocytic cholangitis, also shown to the right, this abnormal bile duct, and moderate interface hepatitis, which you can appreciate. And she had stage 2 fibrosis on Masson trichome staining. Now, I want to call attention to the relationship in AIH, PBC, cholestatic overlap syndromes of interface hepatitis as a source of possible misdiagnosis in clinical practice of overlap. To the left, you see 231 patients that were enrolled in a clinical randomized controlled trial of azathioprine versus placebo. Azathioprine had no impact on the disease, and the patients underwent biopsy annually for 4 consecutive years. Those were read blinded by Hans Popper, and he then constructed these actuarial graphs of cumulative prevalence. I call attention to the red arrow. You see that interface hepatitis on initial biopsies was present in a substantial number of patients, about 70%, and it rose to essentially 100% in these non-ursodeoxycholic treated patients. So interface hepatitis, as well as intralobular lymphocytic infiltration and interlobular hepatitis, are all common in untreated primary biliary cholangitis. Moreover, when one looks, they have abundant B cells as well as abundant plasma cells. And those particular cells secrete preferentially IgM rather than IgG. So we have evidence that PBC can look like an interface hepatitis and lymphoplasmacytic infiltrated autoimmune hepatitis and be PBC alone. Now, in contrast, you see on the left IgG secreting cells in the portal tract and a paucity of IgM secreting cells in patients with pure autoimmune hepatitis. And similar to the bottom, you see the same thing with IgG secreting plasma cells and a paucity of IgM secreting plasma cells. In other words, the opposite type of pattern for the PBC patient. So our question is, in this patient, what is the diagnosis? PBC alone, PBC AIH overlap, or something else? Well, In order to determine whether or not it might be overlap, we want to turn next and assess Paris criteria for PBC autoimmune hepatitis overlap, recognizing that the Paris criteria have never been substantially validated in other centers than those developing and then advancing the criteria over time within the Paris group of PUPAM. These are the Paris criteria, and one sees that the PBC component requires 2 of the 3 diagnostic parameters that are considered the diagnostic criteria for PBC itself. And then regarding the AIH component, one must have moderate to severe interface hepatitis. Thus, a biopsy is mandatory. And if you do not have a biopsy, you should not be considering the diagnosis of a cholestatic variant or an overlap syndrome. In addition, you need 1 or more of the following. Now, at the bottom, I have shown that when one uses these criteria in one of its earlier iterations in the published literature, in the Mayo Clinic cohort of PBC patients, nearly 1,500, that only 8 met stringent criteria of showing they developed an AIH overlap syndrome. You will all recognize this is in distinct contrast to the often quoted prevalence of AIH PBC overlap of 10 to 15%. We have a mismatch here. And so as clinicians, we have to be aware that we may be overdiagnosing this by the application of these parameters that lead to misdiagnosis. So we must follow rigorously these guidelines for the application of something like the Paris criteria. Now, this patient meets all diagnostic criteria for PBC. We have elevated alkaline phosphatase, AMA positivity, a compatible liver biopsy, absence of biliary obstruction. He also meets diagnostic criteria for PBC AIH overlap. She has autoantibodies that include the smooth muscle F actin. She has the elevation of ALT. She has the moderate interface hepatitis with lymphoplasmacytic infiltrates. She happens to have elevations of both IgG and IgM. So how do we then evaluate this case? Well, in my practice, I wish to turn to the International Autoimmune Hepatitis Group expert opinion regarding this circumstance as a source of guidance. In that document, they review the literature and the evidence for 5 postulated explanations for PBC AIH overlap syndrome. Now, I'm not going to go through them all, but at the top, you have the sequential occurrence of 2 distinct independent autoimmune liver diseases in the same patient. At the bottom, number 5, you find where the evidence takes you. That there is a primary autoimmune liver disease with at least 1 or more features of another autoimmune liver disease. And the current status is that the 5th explanation is favored by the data, that we cannot prove or disprove the coexistence of autoimmune hepatitis, either with PBC or PSC, as an overlap, and disease-specific biomarkers will be required to settle this issue. And to date, they have not been forthcoming. So now we take further, having looked at these criteria, suggesting evidence of both PBC and autoimmune hepatitis, and we go to the recommendation of that guideline, which is to observe treatment response of the primary autoimmune liver disease before treating a secondary autoimmune liver disease as overlap. So we started ursodeoxycholic acid, 15 milligrams per kilogram per day for PBC as the primary autoimmune liver disease. The ALP decreased sequentially and normalized by year 1. The ALT decreased to 45 units per liter by year 1. The positivity of all autoantibodies persisted, and her elevations of both IgG and IgM decreased to less than or equal to the upper normal limits. So concluded that her final diagnosis was PBC with features of autoimmune hepatitis responsive to therapy for PBC alone. This is an example of a concurrent presentation that looks like it could be an overlap, but indeed is a reflection of the interface hepatitis and the autoantibody profiles that can be observed in PBC alone. So what if the treatment for PBC did not reduce ALT/AST levels, indicating unmet need for treatment of AIH? Well, what are our choices? We have a budesonide or prednisone monotherapy, steroid and azathioprine after testing for thiopurine methyltransferase enzyme activity, and other options. Now, there's a lack of evidence basis for a choice among those options, but consider that budesonide, in terms of evidence basis, has only been a benefit in autoimmune hepatitis when used with azathioprine. Prednisone monotherapy has been studied, as you're well aware, and prednisone can be have azathioprine or 6-MP added as you're trying to reduce the prednisone dose. So had the patient not looked like PBC, my preference would have been prednisone with a goal of tapering a starting dose ultimately to no higher than 7.5 milligrams per day to avoid chronic toxicities, and addition of azathioprine if required to achieve that prednisone taper. Let's turn to primary sclerosing cholangitis, which you all know is a disease that has an overlap, as shown in the pink to the bottom left, that the classic disease accounts for 90 to 95%, and that classic is large duct PSC observed on MRCP or ERCP, and that approximately 5% are a small duct variant in which the MRCP and ERCP do not show strictures. The pathology of small duct PSC is important because it is a pathology that one can observe in large duct disease when you have biopsies showing only small to small medium caliber interlobular bile ducts, because the actual classic lesions of fibrous obliterative cholangitis of PSC are really only seen in medium caliber to larger caliber bile ducts, often not retrieved with a percutaneous biopsy. So we know that large duct disease, if biopsied, will show principally these findings, and we will use it to corroborate the diagnosis. But it's not terribly helpful in most of our cases of potential overlap syndrome. We also know that PSC diagnosis requires the exclusion of a number of causes of secondary sclerosing cholangitis, chief among them IgG4 sclerosing cholangitis, followed by infections in immunocompromised patients that can create mimics, as well as ischemia and toxic ischemic injuries, as shown on this list to the right. Now let's turn to a case. This is a 45-year-old man with type 1 autoimmune hepatitis and quiescent ulcerative colitis with recent elevations of GGT and alkaline phosphatase. He has mild chronic fatigue. His AIH has been in biochemical remission. His UC has been in remission without specific therapy, although he himself has been on steroid and azathioprine. These are asymptomatic elevations of GGT and alkaline phosphatase. His physical examination showed that he was well appearing. He had no vascular spiders, hyperpigmentation, xanthelasma or xanthomata, and he had no goiter, and he had no hepatosplenomegaly.
Excuse me, sir. Could you check the slide? It's not moving.
You have it here?
Yes. It's the same slide. It's continuing. So
Yes.
you check.
I'm showing it's moving to my medication. You're not seeing that?
No, it's still on the old slides of the diagnostic dilemma. John, maybe there is a discrepancy. Can you check on your side? The slide is not moving.
Well, I'm moving the slide, so I don't know what's happening. I'm just moving the presentation. Let me come out of the presentation mode here.
Yeah.
And see. So where did you last see the slides?
Diagnostic dilemma. That's your last slide.
So diagnostic dilemma, which that was back in, have you seen this slide?
No, we haven't seen this slide.
You haven't seen this slide?
No. You go down. Yes, this is the last slide.
Oh, okay. Well, let's see.
So you start from the slide 25.
Okay. I don't know what to say. It's showing it's changing on my screen.
Okay.
I want to go to presentation mode. Do you see this slide right now?
Right.
Is the group consensus?
Yes.
So let me go to presentation mode. Do you see it now?
Yes.
Now let me change. Do you see the next slide?
Yes.
I don't know why. I mean, this is just what I've been seeing. I've been in presentation mode. So let me go back. I know time is of the essence here, and point out that the essence of this slide is the International Autoimmune Hepatitis Group consensus was that the data regarding overlap is best interpreted as showing a primary autoimmune liver disease with one or more features of another autoimmune liver disease. And that coexistence of AIH with either PBC or PSC is currently not provable or refutable, and we're going to need biomarkers in the future to settle that issue. This then takes us to the need for observation of treatment response of the primary autoimmune liver disease before considering treatment of the secondary autoimmune liver disease. And in this patient, the treatment with ursodeoxycholic acid alone resolved the PBC component, the ALT component, and reduced her IgG and her IgG levels. So it led to the final diagnosis of PBC with features of AIH that was responsive to therapy for PBC alone. And then I asked the question, what if it had not occurred that way? And I needed treatment for the autoimmune hepatitis, and reviewed the steroid and thiopurine possibilities, and shared my preference in such a patient would be a prednisone with a monotherapy with a goal of tapering to less than or equal to 7.5 milligrams per day to avoid toxicities, and using the addition of azathioprine as required to achieve that prednisone taper. Now, can you see this slide for PSC?
Yes.
Good. So I don't know what's wrong. I'm just doing the same thing I've been doing here. So we have the 95% of the cases are the classic large duct PSC. We're concerned, obviously, about the overlap. And we have the small duct variant in 5 to 10%, which have negative MRCP and ERCP findings. Now, this shows the pathology of small duct disease, and the important point here is that large duct disease patients, if biopsied, will show the small caliber intralobular bile duct pathology of a small duct lesion. They don't have small duct lesion, it's just that they have large duct disease, and that's the pathology. You rarely see the fibrous obliterative cholangitis lesion that is classic for PSC, because you don't usually retrieve medium caliber bile ducts that show that lesion on percutaneous biopsy. one always has secondary sclerosing cholangitis considerations. The principal one for all of us is to never miss IgG4, secondary sclerosing cholangitis, because of its the treatment options are different than PSC. So I'm going to a case, 45-year-old man, autoimmune hepatitis type 1 in biochemical remission, ulcerative colitis in quiescence, asymptomatic elevations recently of GGT and alkaline phosphatase, physical examination without stigmata of chronic liver disease. His medications, do you see this slide of medications? George?
Yes, the medications.
Yes, prednisone 5 milligrams, azathioprine 75 milligrams of omeprazole, and he has no herbal or dietary supplements. His laboratory tests show his alkaline phosphatase is approximately 2 times the upper limit of normal. His total and direct bilirubin are normal. His ALT and AST remain in the remission range. His albumin is high, his INR is normal, and his autoantibodies show that he has ANA, an F-actin smooth muscle antibody. His AMA is undetected, and his P-ANCA was detected at 1 to 80. His immunoglobulins show that it had been elevated and then decreased on therapy for his autoimmune hepatitis. So here we have the need to consider imaging, and as before, we could consider liver biopsy. But I hope that I have convinced you that liver biopsy is relevant only if you have diagnostic doubt. But you do not want to perform it in order to detect those lesions that might be confusing with small duct PSC, because in the absence of macroscopic large duct disease, we cannot make the diagnosis of PSC, autoimmune hepatitis overlap. So we pursued this, and here are examples of MRCP and ERCP showing the typical beaded appearance of stricturing and ectasias of a sclerosing cholangitis. To the right, one sees the newly FDA-approved MRCP Plus from Perspectum that takes the data within MRCP and reanalyzes it as a heat map showing strictures, which are outlined by the arrows that you see against this heat map. And this is something we hope will be helpful clinically, because one sees here in the top row MRCPs that were difficult to interpret in a randomized controlled trial conducted in PSC patients. And then one sees the retrospective analyzing of the data within those MRCPs now with this new technology and the caliber of the bile ducts. And so one can more easily see areas of involvement in stricturing. And one can also see the heterogeneity of the appearance of the biliary tract in patients with PSC. So this may be more helpful to us as we go forward for indeterminate MRCP results to be reanalyzed using MRCP Plus. Well, this patient's MRCP showed typical intrahepatic stricturing ectasias, no dominant strictures, no luminal obstruction. So we concluded in this patient that biopsy was unnecessary. We already knew he had verified autoimmune hepatitis. We just diagnosed large duct disease, and we do not need to find evidence of PSC, which would be confusing with small duct disease, by conducting a biopsy. So we next wanted to assess current criteria for overlap syndrome. These are those criteria, and these, as with the Paris criteria, lack validation. They principally lack validation of the left column, in which the application of the AIH simplified diagnostic score that Professor Tanaka reviewed for you was used to diagnose the AIH component. This is inappropriate in the sense that this diagnostic score was developed and validated only in patients with autoimmune hepatitis who had a classic form of autoimmune hepatitis and were not difficult to diagnose patients. The PSC component in the right column are much more straightforward, and I've bolded for you the things that stand out diagnostically in favor of PSC in this particular patient's MRCP. But we must therefore continue and now exclude causes of secondary sclerosing cholangitis, which I re-show you, we did. He had no IgG4 evidence. He had nothing to suggest infectious ischemic, toxic ischemic, or neoplastic changes as an etiology of his strictures. So now we have to conclude the next step is to consider treatment for PSC. Now, you're well aware that there is no proven therapy for PSC. So if one were to say, I have no therapy and I would now observe my patient, you would be perfectly correct within our use of evidence basis. However, you also know that there are data that have been developed from the Scandinavian PSC randomized controlled trial of high-dose urso, 17 to 23 milligrams per kilogram per day, that in the 14-year follow-up suggested some patients with PSC might be responsive to those doses of ursodeoxycholic acid. Thus, we have developed a protocol illustrated here, and you want to pay attention to the left-hand side of this diagram to offer patients ineligible for participation in randomized controlled trials the option of being empirically treated with a goal of urso of 20 milligrams per kilo per day, and the endpoint of looking for a 40% or greater decrease in their baseline alkaline phosphatase. If that's not achieved within a year, we stop the therapy and again, would have them reconsider after washout possible inclusion or participation in a clinical trial. Now, this is entirely empiric, but it's not unique to us. The Mayo Clinic has a similar protocol in the United States. So what we're doing with this protocol is trying to find those individuals that might be responsive because we have no predictors that allow us to identify them before such treatment. So his clinical course was that we treated him because of the tablet sizes, capsule sizes. He ended up at 21 milligrams per kilo per day. He had AIH maintenance immunosuppression. His ALP fluctuated but did not increase. His total Billy ALT, AST remained within normal limits. His autoantibodies were not retested. So our final diagnosis was verified AIH with development of PSC, and we await whether he will or will not show a treatment response as we continue his therapy over this proposed period of 12 months. I want to thank you all for your attention to my algorithmic approaches for patients with AIH and overlap syndromes, calling back your attention to the fact that I prefer to call them cholestatic variants because it forces you to entertain a broader differential diagnosis. I look forward to your questions. Thank you very much.
Thank you, John. This is really a Top Gun lecture on the topic. And having you being the speakers really enlightens our Asia Pacific colleagues. We apologize for the technical problems we have.
It was my fault. I don't know what happened. I just was changing the. You obviously weren't seeing the change.
It's a very nice discussion, and I really appreciate people like you can bring up slides in the 1980 in the publishing gastroenterology, and it's really iconic when the times with Hans Poppers and doing all the studies, and it's really the track. Having said that, I would like to pass on to the Professor Lin, who would like to initiate the Q&A sessions after the two very delightful sessions with Professor Tanaka and Professor Mary.
Yes, there's a question from the attendee for Professor Tanaka. The question is, I would like to have your comment regarding acute severe AIH in muffled, any different approach? Professor Tanaka.
Is Professor Tanaka here?
Professor Tanaka, can you? Oh,
I'm sorry.
Okay.
Yeah. Okay. Now you can hear me. I'm sorry. So it's a very nice question. So we can encounter this kind of patient in clinical practice, and my answer is the the approach should be the same, because in most cases the treatment response will be faster in corticosteroid compared to other thiopurine or other immunosuppressive drugs. But in cases with acute severe autoimmune hepatitis, either with muffled or without muffled, we need a prompt response to treatment. Otherwise, the liver failure is progressing and leading to mortality. So we need a prompt response. So that's why I prefer the treatment with corticosteroid other than other immunosuppressive drugs, even in cases with severe autoimmune hepatitis in muffled. Yeah, that's my answer.
Thank you. Professor Tanaka, I would like to look for your comment. Right now, the anti-TNF-alpha agent has been used widely, and it could induce some people report that they can induce AIH. And can it be present as an acute severe form?
Oh, I'm sorry. Acute severe form with autoimmune hepatitis induced by
anti-TNF-alpha.
Oh, okay.
Anti-TNF-alpha.
Yeah. Oh, okay. Okay. Thank you very much for your question. So I've never experienced that kind of case, but the answer would be the treatment option would be the same. So probably we need to treat that kind of patient induced by anti-TNF-alpha with corticosteroids because of the same reason. So we need prompt response to treatment. So first we should treat that kind of patient with corticosteroids, then maybe followed by the thiopurine or mycophenolate mofetil.
And there's also a question from the attentive to Professor Tanaka. The question is there any role of CT scan in fulminant AIH as rapid morphological change occur during fulminant course?
Excuse me, so what is your question? Would you repeat the question?
Is there any role of CT scan in fulminant AIH as rapid morphological changes?
Okay. CT scan.
Yeah.
Oh, yes. I believe that the role of CT scan is definitely present for diagnosis of fulminant or acute severe AIH. So some clinical studies investigating the role of CT scan demonstrated that some morphological change of the liver in case with acute severe autoimmune hepatitis. So I told in my presentation that the diagnostic criteria for acute severe AIH should be determined in the future. But I believe that CT scan or other imaging studies would be included for required for the diagnosis of acute severe autoimmune hepatitis.
And there's a question, I think it should be to Professor Verlin. The question is, what is elevated IgG with subclass heterogeneity in AIH overlap? For example, specific IgG4 positive rate or IgG4 specific cloned B cell infiltrating?
That's an excellent question. And we have evolved in our understanding of IgG4 pathology. And we didn't have time in this lecture to go through the fact that IgG4 disease, as you know, can affect any organ in the body. So we're focused now on the liver. And in the liver, it does have is very much compatible with a mimic of autoimmune hepatitis, an IgG4 form of autoimmune hepatitis, without evidence of sclerotic lesions on MRCP. In addition, we have on the opposite side sclerosing cholangitis, is considered a secondary form due to IgG4, with or without pancreatic duct involvement. So that kind of brackets what we're speaking about in terms of IgG4. Now, we once looked at IgG4 levels as part of the diagnostic criteria, which are there's multiple diagnostic criteria. Don't have time to go into those, but the levels can be misleading. And this led then to the concept that you want to look in a pathology and quantify IgG4 secreting B cells or plasma cells. I think that for the tough case where the IgG4 levels, which you would probably send routinely, are confusing or non-diagnostic, that having the pathology is key, because we can make a diagnosis on the basis of cells, and I prefer that. So one could look at a new biopsy. Sometimes you have an archival biopsy where it can be resectioned and stained. But I think that there is in favor of a cellular analysis for accuracy of IgG secreting cells being quantified.
Okay, thank you.
Professor Lin, Professor Lau, may I speak? This is Kadir Dökmeci.
Yes, please, Professor.
Yes, please.
Thank you very much. Thanks, Professor Werling and also Tanaka for their excellent speech. I have the question to Professor Tanaka. Diagnostic criteria such as clinical findings, laboratory tests, immune tests, and also imaging tests shows the autoimmune hepatitis. Do you perform liver biopsy without any exception, or how often do you use liver biopsy in those cases?
For diagnosis of autoimmune hepatitis in that kind of cases, in my experience, usually I conduct liver biopsy in every single case with suspicion of autoimmune hepatitis, even if classical AIH or acute severe onset hepatitis. And in patients with severe coagulopathy, where practice liver biopsy should be avoided, we can conduct liver biopsy via transjugular route. And so yes, of course, if the patient is denied the liver biopsy, so we cannot do that. But I believe that we should conduct liver biopsy in every case with suspected autoimmune hepatitis.
Thank you.
John, what do you think?
Well, I think biopsy is always relevant and helpful in these cases, in particular to be sure we're not missing something other than what we're considering in our differential diagnosis. We would favor the transjugular approach in those with even very mild coagulopathy. And so I think that Professor Tanaka is entirely correct. I think in these cases, one of the helpful aspects that Professor Tanaka emphasized is when is treatment with immunosuppression becoming futile? And you should withdraw it so that you do not set the patient on a course for opportunistic infection that would contraindicate liver transplantation. That liver transplantation is going to be the therapy of choice. And the biopsy in these acute cases can be helpful when you assess the percent of the parenchyma that's necrotic. So sometimes you're surprised by the actual laboratory results, AST and ALT, as you find that biopsy done transjugularly shows 40% or more of the parenchyma being necrotic. That patient is very unlikely to respond to continued immunosuppression. That patient is much more likely to require liver transplant. And that's one of the advantages of the biopsy. It helps you direct the patient to the therapy that will be life-saving.
Thank you.
Thank you. There's a question from the attendee to Professor William. the question is, what about fibrate in refractory cholestatic overlap syndrome?
Well, that's a very interesting question. And we have to, I think, deal at two levels. One is somewhat of an emerging but persuasive anecdotal evidence basis for fibrate use in cholestatic disease, in particular primary biliary cholangitis. There's really not a credible such literature or expert opinion recommendations for PSC. But we have to note that it is not evidence-based. We do have for bezafibrate credible evidence of effectiveness and safety in PBC. So we do have that. However, in the United States, we have no access to bezafibrate. So our fibrates would be the PPAR alphas, that would be fenofibrate or others. We do have, unfortunately, in fenofibrate, because of toxicities that were originally observed, we have an FDA package warning in fenofibrate that it not be used in a patient with primary biliary cholangitis. Now, that's probably an overstatement, but it's there, so it has medical legal implications in the United States if one were to use the fibrate and end up with one of the idiosyncratic forms of hepatitis that can occur with fibrate use. And that's true. The bezafibrate study published in the New England Journal had such cases. And it's the reason that that was ascertained as a safety concern by the FDA in the original registration trials of fibrates. So I am not in favor of the empiric use of fibrates at this moment. I am in strong favor in PBC that we continue to process and enroll to completion the elafibranil trial of sort of an alpha dominant, slightly a subdominant, seladelpar trial of a PPAR delta, a dominant form of fibrate, and answer the question scientifically.
Thank you. I think because the time is limited, so we have to close this e-learning this evening. And thank you for both the speaker for your excellent speech, and also thanks for Professor Lau for your co-chair. Professor Lau, anything to say?
Well, I think this is an excellent session. It's a very learned experience. And John has been my teacher for more than 40 years. And Professor is the rising stars and new leaderships, shows the new leaderships in Asia Pacific regions. I'm sure the colleagues in Asia Pacific region enjoyed the sessions. And thanks for the presidency of Professor Lin of having these sessions done. And I would like to close the sessions and thank you for all joining this wonderful evening. Thank you very much.
Thank you.
Thank you very much. Thank you. Bye-bye.
Thank you, George. Thank you, Tanaka. Bye-bye.
Thank you.
Thank you very much, George. Thank you, Professor Lin.
Thank you. Bye-bye.
Good to see you,
Very
Sushi.
much.
Hope to see everybody in person sometime soon.
Sure.
Yeah.
Bye now.
Ben de toplantı yaptım. Konuştum. Ne toplantısı? Japonya. Nasılsın babacığım? Çok güzel oldu. Bağa gidiyor. Bağa geri gidiyor. Şimdi bir şey aldı gidiyor. Ne aldı? Kesin bir şey aldı. Güne göre iyi ama. Güne göre iyi, evet. İçerisi sıcak.